A very good morning, ladies and gentlemen. Welcome back to the second consecutive day of SLC TRIMS 2026, the 7th Annual Congress organized by the Sri Lanka Committee for Treatment and Research in Multiple Sclerosis and Related Disorders. We have different engaging sessions lined up today, and we kindly request you to keep your phones on silent mode during the presentations. Now let us move on to the Symposium on Autoimmune Encephalitis. May I invite the chairpersons, Professor Tershit Chang and Dr. Senaka Bandasena, to introduce the speakers. Over to you, sir.
Good morning, everybody, and welcome to the second day of the Congress. And we start off with the first symposium for the day, which is on autoimmune encephalitis. We have three eminent speakers lined up for this symposium. And it is my great pleasure to introduce the first speaker, Professor Sarosh Irani. I have known Sarosh for over 20 years now because our paths crossed in Oxford when we both did the DPhil in the same laboratory. Professor Sarosh therefore went on to become the Professor of Autoimmune Neurology and Consultant Neurology at the University of Oxford initially. And then subsequently he has now moved to the Mayo Clinic in Florida, where he is the Professor of Neurology and Neurosciences who leads the Autoimmune Neurology group there. Sarosh is well known and credited with discovering the LGI1 and the Caspar-2 antibodies, which, as you all are aware, has revolutionized how we treat, how we diagnose and treat autoimmune encephalitis today. He also is the pioneer in describing the fatiobrachial dystonic seizure, which is almost pathognomonic of the LGI1 autoimmune encephalitis. So it's an absolute privilege and honor, and Sarosh has been to Sri Lanka before, so we hope he will come again. So over to you, Sarosh.
Thank you, Tashi. It's great to hear your voice. And you're right, it's been 20 years now almost. I think about 5 months short of 20 years since we met. So great to see you again. And as you say, I came to Sri Lanka last time. You kindly invited me, and it was a really fantastic time we spent there. So thank you for that invitation. And I certainly hope we can do that again soon. So some disclosures. I thought I'd start on this slide because most of the audience will be very familiar with this concept, but of course the field of autoimmune neurology, not just encephalitis or NMO or any other specific syndrome, has really expanded rapidly in the last 20 years. In fact, since Tashi and I met, you can see this has gone exponential. Since the discovery of aquaporin 4, then NMDA, then LGI1 Caspar-2, this field has really gone rapidly upwards certainly in terms of the number of antibodies described. And therefore, although some of them become very rare recently, the number of syndromes associated with it, and what I often call not to miss clinical conditions. Because, of course, as these patients respond to therapy, we always are extra vigilant not to fail to diagnose these conditions. And I'm going to concentrate principally on the antibodies that are in the upper half of this diagram, in the blue triangle, because these are the antibodies which bind extracellular targets and which are almost certainly pathogenic in these illnesses. So it's a very linear approach to say, okay, we've got an antibody, it causes the disease, we mustn't miss it, these patients are immunotherapy responsive. And so it's a very important paradigm that's been highlighted in the last few years. And I think the other thing that strikes me about these illnesses is that the antigen, the autoantigen, defines so many fundamental features about these patients. And that's I think it's a really difficult to explain phenomena, and one which really requires some careful thought. For example, there are some diseases which are predominant in young people. These are diseases which are fundamentally defined by the autoantigenic target. So how can the antigen dictate the age of the patient? Conversely, how can the in this case, there's a bit more of an explanation, but still, why this antigen of these five at least has the highest tumor association? And why do two of these antigens associate very strongly with certain HLA molecules? There are other examples. For example, why do LGI1 patients, why are they the only ones really to have a hyponatremic syndrome? Because presumably the antibodies bind in a region that affects ADH secretion. But nevertheless, despite there being some pathophysiological explanations along the way, the big question of why these associate with the antigen per se, I think is still really perplexing and really hard to understand. But my principal remit today is to talk about encephalitis, or as I've learned to say over the last 2 years in the US, encephalitis, and learned to try and think about this in terms of criterion, in terms of definitive diagnostic criterion. So here are criteria to diagnose encephalitis generally, not just autoimmune or infectious, any form. And you'll see that most patients you can think of that you feel fit into the rubric probably do, because these are very broad criteria. Once you've got a fever, cognitive change, once you've got cognitive changes, then a fever or a seizure or focal neurology or a white cell count, you basically fit into this as possible or probable. But nowadays we often think, okay, so we're at this crossroads, we're at this point where we're thinking, do we give immunotherapy to our patients, or do we give them antimicrobial agents? And that's a really difficult decision sometimes, especially if you're being a purist about things. It's a difficult decision because, of course, there are very few clinical features which really tell the difference between these two diseases. I think headache appears to be very useful because it's basically absent in most patients with autoimmune encephalitis. It's definitely not a universal say-so, but this study gives us really only clues to headache and fever, which appear to convincingly differentiate these patients. Yes, there are other p-values there, but if you actually look at the numbers, the percentages overlap quite substantially. So really, I think it's headache and fever which give you a clear inclination towards being present in infectious forms of encephalitis. And so you need other tools to really help you. And we studied this a few years ago because we'd had radiology meetings for almost a decade in the UK trying to work out the difference between the scans that we were seeing. And we began to see a really clear pattern, and we wanted to test that in a blinded way. So what we did was we looked at patients who had LGI1 or Caspar-2 antibodies, that's the top row here, or infectious forms of encephalitis, mainly HSV, and then patients with CJD, who of course have a neurodegenerative condition. And Mark Kelly, who'll be actually coming to join us as the next fellow here at Mayo, Florida, was delineating in a graphical style the areas affected on a T2 scan, T2 weighted scan in these different diseases. And essentially, the red is the summary of the T2 results. What he saw was that in autoimmune patients, in the top 55 patients here, there was dominance of the medial temporal lobe, a little bit outside of the medial temporal lobe, but really very rarely very far outside. And even then, very little, say, in your parahippocampal gyrus or your entorhinal cortex. Whereas in viral cases, the T2 signal was much more distributed, widely distributed. And in CJD, it was a little less, it was still distributed, but in few patients. The really striking results that give you clear predictive power are that diffusion restriction was absent in the autoimmune patients, but almost universal in the viral and in the CJD cohort. And contrast enhancement, again, was almost absent in the autoimmunes, but commonly present in the viral patients. So collectively, these three features give you a really robust area under the curve, approaching 1, and so help you differentiate between autoimmune and infectious in that acute phase. So the autoimmune condition we were talking about there was LGI1 antibody, encephalitis. And of course, this is a very distinctive disease. This is a disease which occurs predominantly in people around 60, 70 years of age. And for an autoimmune disease, it's unusual because men are affected more than females. And the tumor rates are equivalent to those in the general population. Seizures, though, are the real hallmark of this disease. Not so much the cognitive impairment. The seizures are the real feature that define this disease. I'll show you some of them in a minute. You heard from Tashi Chang a few minutes ago that the faciobrachial dystonic seizures are very, very characteristic, but there are certainly other characteristic features, seizures as well. And neurocognitively, this disorder predominantly appears to localize to the medial temporal region with quite dense amnesia, often a HM neuropsychological case-like amnesia, with often our patients won't remember us coming into the room just 10 minutes before, the real difficulty laying down new memories, but also a retrograde component, often with retrograde gaps. These patients have disorientation, behavioral changes, and many of them cry in an unprovoked fashion. So emotionality is a very common feature in these patients. And as you might remember from the figure I showed earlier, many of these patients have a serum hyponatremia, but of course that's a very non-specific feature in these illnesses. Now, the faciobrachial dystonic seizures are the pathognomonic feature of these illnesses. They involve the arm and the face. About a third of cases will involve the leg, and patients can often fall due to that. They will typically occur for 1 to 2 seconds, maybe a few seconds more in duration. And the really striking thing about these is that they occur often tens to hundreds of times per day. So I often think of these as entities which, if you don't see when you go to meet your patient, you've got to think twice about whether this is, especially when they're at their worst, when they're at the nadir of their illness. And here's an example of one. If you watch the side of the camera closest to us, face, arm, and leg, just a very subtle one there. You saw the leg got drawn up, the face and the arm were affected. He knows something's happened. He's just shook it off, and he keeps working. This patient's particularly interesting in that he keeps working through this. His emails are normal. You saw he just had another one. But his cognition appears to be preserved. He held down quite a high-powered job in the UK during this time. And so there are a group of these people who don't seem to have encephalitis in its typical form, at least. As neurologists, we're sometimes guilty of collecting stamps for the sake of collecting them. But I think it's important to question why these events are important. Why is it important to recognize FBDS? Well, the obvious reason is that these patients have a really very poor, typically, response to anti-seizure medication. So looking at this figure, only 10% of them here will show a complete seizure cessation on anti-seizure medications. And the reason 2 of them look impressive here is because most of these patients have been given immunotherapy. And if you now look at about 90 days here, you'll see that around that 3-month mark, 80% of patients have become seizure-free. So it's a really great number. If you were a drug company, you'd be super happy with that. You'd think, great, my drug really works in these patients. And this is just a combination of steroids, IVIG, and plasma exchange. But these patients do have a lot of side effects on some of these medications. And in fact, I have now largely stopped giving anti-seizure medications to these patients with, of course, perhaps the commonest adult onset seizure semiology across the whole of neurology, because a lot of them develop rashes on their anti-seizure medications. So not only are the drugs ineffective, but they develop nasty side effects on them. Many of these are Stevens-Johnson syndromes. The other reason this is not just stamp collecting is because I think we can potentially change the natural history of this disease. So this was a study we did when we began to realize these seizures are preferentially immunotherapy responsive, because quite soon after, we were asking the patients, tell us about what came first in your illness. What was the very first thing you noticed? And they would nearly always say, 80% of them above the x-axis here would say the seizures came first before the onset of cognitive impairment or amnesia. And if you look at that, therefore, you might say that if you treat these patients, treat their seizures, can you stop the onset of cognitive impairment? And that's exactly what we saw. So the dotted line here are the patients who were treated and their seizures stopped, and they have not, on the y-axis, developed cognitive impairment, except for one rogue patient, as there always is in medicine, right? But the majority of them, if they're having ongoing seizures here in the dark line, they continue to accrue cognitive impairment, develop new cognitive impairment. So I'm pretty convinced we can completely change the natural history of this disease. One of the other questions is this disease really encephalitis? Is it really a form of inflammation, and does it fit the diagnostic criteria for possible autoimmune encephalitis? Well, if we tackle that feature by feature, we see that these patients, about half of them will have a progression of less than 3 months, but half of them will be there worsening at presentation for more than 3 months. Very few have focal CNS features. Nearly all have seizures. Only about 20% will have cells in their CSF, so CSF pleocytosis, and only about 50% of them will have an MRI which suggests encephalitis. Most will have a normal MRI nowadays, especially, I'm sure, as we're seeing them earlier and earlier. So they don't really fit typical features of encephalitis. And so we began to realize that because of this, because of these unusual features that I showed you in the acute phase, because they don't really fit typical criteria, we thought that traditional outcome measures would be insufficient to understand these patients' outcomes. So we started to develop our own outcome measure specific to this disease. We called it a patient-reported outcome measure because it involved a narrative interview with the patients where you ask them to tell you things that affect them. Then you go through rounds where you narrow those down, you retest them and you validate them, and you end up with a final questionnaire, which you can see had a number of categorical domains here, and which correlated with each other pretty well. And here are the actual features, which included fatigue, the features of fatigue, so weakness, if you like, requiring assistance, sleep problems, seizures, cognitive problems, mood problems, and then functional problems, activities of daily living. And these are the features which mattered most to the patients. These are the features which our patients told us really made a difference. And when you look at those features on the right-hand side there, and we named the patient-reported outcome measure LANTERN, which was an acronym generated, I'm sure, by ChatGPT at some point, we compared them to the conventional scales. The most conventional scale used in pretty much all studies is, of course, the modified Rankin scale. And you can see in the modified Rankin scale, only a small number of the patients actually rate as abnormal. Whereas from the LANTERN scale, nearly everyone has at least one abnormality, which is much more representative of what we see in clinical practice. It's much more representative of this column here, the EQ5D5L visual analog scale, which is essentially a quality of life rating from the patients from 0 to 100. And it somewhat reflects some of the more nuanced scales used, such as fatigue, anxiety and depression, and neuropsychological outcomes. So we're beginning to see something which will allow us to now more accurately measure how our patients have done in the long term. The cousin disease of LGI1 is Caspar-2, and it's not just a cousin because biochemically the antigens both occupy the VGKC complex, but these patients also have frequent focal seizures. They're often of the same age group. You'll see this patient here who has a very unusual semiology with these attacks happening 5, 10, 20 sometimes times per day. And you'll see they also have another feature, which is neuromyotonia. Here's their video of peripheral nerve hyperexcitability. And I show you someone's abdomen because it's important to remember that these attacks happen in unusual places on the body as well as look distinctive in their own right. Often trunk, often chest and back, face, sometimes tongue. So unusual representation of these features is the other characteristic. And as I said to you, you saw from the first patient's face, these are usually men and they're usually above 60 years of age. So here's the demographics, males to the right, females to the left. It's about an 8-to-1 ratio of male to female. And you'll see that most of the patients here in blue have limbic encephalitis. Some have Morvan syndrome, which is this overlap syndrome, and few have peripheral nerve hyperexcitability. But the first syndrome described was peripheral nerve hyperexcitability, but actually the limbic encephalitis is definitely more frequent. The tumor associations are predominantly thymomas, but we're increasingly convinced that many of these patients have prostate cancer or prostate hypertrophy. And that's really intriguing to me because the prostate is the only other organ which expresses, the only other tissue which expresses Caspar-2. And these patients have features which can be neatly divided up into traditionally, if you like, neurological and neurocognitive features, dysautonomia and insomnia, which is this hallmark of the Morvan's patients you'll see there, and then peripheral nerve hyperexcitability, and also commonly neuropathic pain. And the reason I emphasize neuropathic pain, you'll see on the next slide, but a bit like the LGI1 patients, not many of these patients have an abnormal CSF, abnormal EEG they can have, but of course that's non-specific, or abnormal MRIs. So often those findings are normal in these patients. And the reason I mentioned fatigue and neuropathic pain previously is because we began to study this for a number of reasons. We began to characterize the distribution of the neuropathic pain. You'll see on the left is the LGI1 patients, where it affects the trunk very often, but is distal and length dependent in nature, and is almost certainly due to a small fiber neuropathy, whereas it's more exclusively distal in the Caspar-2 patients. And in the LGI1 patients, this is a pain interference score, which the patients rate themselves. The neuropathic pain appears to get better with therapy, post-immunotherapy, but in Caspar-2 patients, it's highly refractory typically. And in fact, if you look at outcome measures of these patients, features which prognosticate these patients and give you a predictive value for how they do in the longer term, one really striking thing is that neuropathic pain and fatigue actually predict how they do at 2 years in their MRS score, in their quality of life score, and then in their longer term relapse risk better than the age or the syndrome of the patient, the time to immunotherapy, or the use of steroids. So it's really quite striking. These features that we've only learned about relatively late in the illness are the features which seem to matter most for prognostics in these individuals. In NMDA receptor antibody encephalitis, things were a bit different. Of course, this is a young onset illness. You'll see that here. But there is this bimodal distribution with this later onset peak. And these patients often have a carcinoma, whereas as in this dark pink box, you'll see the younger patients have a teratoma and are female, because this is, as you know, usually an ovarian teratoma. This is the stereotype progression of these patients through features where they often develop psychiatric features, neurocognitive features, and then go on to develop a movement disorder, lose consciousness, and develop a dysautonomia. The movement disorder is often very characteristic. I won't show you much of that today, but the psychiatric disorder is, I would say, potentially even more characteristic and maybe even highly distinctive. And I'll show you two studies which were led by a psychiatrist who was my PhD student, is now setting up his own group called Adam Al-Dawani, who thought of a very clever thing to do with his Christmas holidays. He said to me, I'm going to go and review the literature on these patients because of the last 4 patients we saw. He said, and we talked about this by the bedside of these patients. We said, look, it's quite unusual. These patients appear to capture almost everything in a traditional psychiatric interview. So if you go down 50 points of a traditional psychiatric interview, you can see them here. These patients have some of everything there. And many of these things, these smaller criteria, these smaller features, box into larger categories like behavior, psychosis, mood, catatonia, and hence all seem to coexist in individual patients. These were the 7 features which coexisted the most and explain the majority of the variance in the data. And actually, if you look at the overlaps here, many of the patients lie right in the middle or in the intersections of these categories, often coexisting with psychosis, mood and behavior and sleep problems in a single patient. So, of course, this led to this, perhaps I think we can now call it false dawn, where we started to think, the field started to think, do NMDAR antibodies account for primary psychiatric illnesses? But the time course is very, very different. In a paper that was just published last month, we showed that the time course to the onset of psychiatric symptoms was almost always 1 day in the NMDA patients, i.e. it was the first feature. Whereas if you pick patients with unselected psychosis or psychosis selected because it's super severe, you'll see these patients present much, much later down the line. Also, and I'm not sure this projects, but it's intended to show you the pattern more than anything. If you take those features I showed you previously, those 50 interview features, traditional neuropsychiatric interview, you'll see some of them predominate at the top in the NMDA patients. Some of them show no difference, and some of them show a bias towards the psychosis patients over the NMDA patients. Interestingly, these features here are all catatonic, so that's a very specific feature in the NMDA patients. Not perfect, of course, but it's highly valuable when it's there. And there's a number of other features which I'll leave you to look at now or in the paper. But really interestingly, in black here at the bottom, these features, such as auditory hallucinations, thought insertion, grandiose delusions, thought broadcast, paranoid delusions, are all classic features, so-called Schneiderian first-rank features. So these patients are not presenting with typical schizophrenia. In fact, they are actively not presenting with it, right? It's not just that they're absent, they're actively not presenting with it compared to psychosis patients. And if you look at how these features change in the NMDA patients, you'll see very interestingly, and this concurs with clinical practice again, these patients often have mood difficulties as their first feature, not what neurologists at least would traditionally call psychosis. So they move through these mood features of depression, mixed affect, irritability, mood instability, anxiety, through a number of other features in just 30 days or so. So they're so different to most forms of psychosis that are otherwise unselected. The other piece of evidence, and there are many now, to suggest that NMDA antibodies don't account for primary psychiatric illnesses is this. This is our meta-analysis of all the studies in psychosis and psychiatric illnesses which tried to show the serum prevalence of NMDA antibodies. And here's the serum prevalence, which remarkably can rate from 0 all the way through to 30-something%. And obviously that's a bit of a difficult thing to believe that some of these patients, I shouldn't say 30, more like 20%. But what's really striking is that when you look at those individual cases, actually very few have NMDA receptor antibodies in their spinal fluid. And when they do, they nearly always have neurological features as part of their illness. So I'm pretty clear that these antibodies don't account for primary psychiatric illnesses and maybe account for a remarkably small percentage, in fact, of primary psychiatric illnesses. These patients are treated a bit differently to the LGI1 patients. These patients are treated with steroids, IVIG, and plasma exchange, and 50% will improve at 4 weeks, with a plan to improve the others later, because if you fail first-line therapy, you still have a significant mortality rate. But if you then receive second-line therapy, your mortality goes down and your good outcomes increase. Second-line therapies include rituximab in particular, but cyclophosphamide as well. And rituximab in particular shows this association with being more of a monophasic course. So not only improving the first episode, but stopping you relapsing. And it might be in some patients that third-line agents such as tocilizumab are required. Briefly, I wanted to talk about this super interesting illness which Dr. Grouse and Dalmau described, associated with IGLON5 antibodies, because it has this overlap between neuroimmunology and neurodegeneration. The patients present with a sleep disorder, a bulbar syndrome, and a movement disorder, but they have tau in their brain in an unusual deposition. They have a strong HLA association, and if you look carefully at the start of their illness, they have a proportion of them have white cells in their CSF. So this unusual balance between, is it autoimmunity first or is it neurodegeneration that comes first? Well, first of all, we were a bit worried that these patients wouldn't improve. In this study, a retrospective study of the first group of patients, essentially all of them died. But actually, when you look now that we've recognized them a bit earlier, thanks to this first set of discoveries, we can treat them a bit earlier. Many of them now stabilize or improve. And in blue, it's particularly those that were treated at less than 1 year from onset that did well in the longer term. One slide on each of the next three. GABA B receptor antibodies often show this limbic encephalitis with this swelling of the limbic regions, and 50% of these patients will have a small cell lung cancer. They often present with bad seizures and can present with NORS, new onset refractory status epilepticus, as one of their common syndromes. The GABA A receptor antibodies often have this distinctive imaging with fluffy cortical and subcortical white matter lesions. And whenever I've been sent a scan that looks like this, they've always had GABA A receptor antibodies. And something that I'm sure Dr. Flanagan will comment on, as he's contributed much of the work to this disease, are the MOG antibodies, which can associate with various encephalitic syndromes. And I think more and more appear to be an antibody which we should consider in this encephalitis differential more commonly than perhaps we do right now. Finally, I just wanted to say in my last slide that the other really difficult balance is trying to work out when these patients don't have autoimmune encephalitis. This is a big problem in this series that Owen Flanagan put together. It's a very common problem, in fact, more common than actual autoimmune encephalitis correct diagnoses. And usually patients are misdiagnosed because their clinician diagnoses them despite an insidious onset, in the context of a normal MRI, and often in the context of poorly tested or low-level autoantibodies. And in fact, we've got really skeptical about diagnosing seronegative autoimmune encephalitis at all. And in fact, the 3 patients that I've diagnosed with that since I've got to Mayo, all of whom I write, in bold font, probable, they all three of them have done things now that make me think that they're not going to have autoimmune encephalitis in the long term. They've done unusual things for autoimmune encephalitis. For example, one of them keeps breaking through with seizures when without even weaning medication. So there are some unusual features here for some of these patients, and many of them, of course, develop significant side effects on immunotherapies. So I hope that was interesting to you. This is just a quick summary of the things, the main features of each illness, and then just to remind you to be really beware of diagnosing seronegative encephalitis. This is my new home. This is our lab. This is 10 minutes from the lab, which is really great. And this is the building we work in and the team that we have assembled. And this cake here in the circle is my daughter's new baking skills, which combines the 3 shields of mayo with my favorite molecule, with its heavy and its light chains there. Lots of people to thank, many of whom I haven't even yet got round to putting on these slides. But thank you all for your attention. I hope you found that interesting.
Thank you, Sarosh, for that very comprehensive and exciting lecture. Now the floor open for any questions. Sarosh is happy to take any questions.
Hi, Sarosh. This is Peter Hartung. A great talk. I much enjoyed it. I have one question regarding the Caspr2 antibody encephalitis. You mentioned that neuropathic pain is a very conspicuous feature. What about CIDP-like neuropathy? Because, as you know, some of the patients with restricted PNS disease do have antibodies to Caspr2 around the node of Ranvier.
I think it's a really, really interesting question. I'm not sure it's been properly answered yet, but most of the patients that I've seen with Caspr2 antibodies and a peripheral nerve syndrome, a sensory peripheral nerve syndrome, have had a small fiber neuropathy. And nearly all have a small fiber neuropathy clinically, and on a skin biopsy, that's pretty much always confirmed. There's one really interesting study out there that I often reference because I haven't seen a better study since, where they did peripheral transfer, passive transfer of antibodies against contactin 1 and with Caspr2. And interestingly, they say that the paranodal proteins, the antibodies can access those, but the juxtaparanodal proteins are perhaps hidden underneath the myelin sheath. And so maybe the antibodies can't actually reach just under there into the juxtaparanode. So I leave that open because these are sort of piecing together things. But overall, I think it will probably be that this is dominantly a small fiber neuropathy, and perhaps the antibodies can't quite gain access under that myelin.
Thank you. And another ignorant question is, in general, what do you think is the source of any of these autoantibodies? Periphery, CNS?
So in nearly all of these diseases, and in nearly every patient we've tested, the antibodies are higher concentrations in the serum than the CSF. That's like, I suppose, a bit of a simplistic answer to your question. But one thing we did recently was we cloned the plasma cells from the CSF of these patients, and we showed that super high numbers of them, in some patients, 100% of them, react at the one target, for example, Caspr2 or LGI1. And when you try to work out what contribution the clones in the CSF have made versus the peripheral contribution to that antibody, it's nearly all the mutations in the affinity are acquired peripherally. So I'm pretty convinced that these diseases commence peripherally and then make their way into the CSF.
Thank you so much.
Professor Sarosh, if I may ask a question regarding LG1I and Caspr2. Now, when you get the antibody, how long does it last? And when you treat, how long should you treat? Do you have any idea? Like, is it something that lasts years and years, or?
Yeah, it's a very good question. So I think you're right. Yes, it does last years and years. If we've just published something on Casper-2 and we've got the same data on LGI1. In fact, in some patients, it's really hard to get them to hit the x-axis, even after 3, 4, 5 years. So the antibodies seem to go on a long time. But I think there's a dissociation between how long you need to treat the patient and how long the antibodies persist for. Why? I'm not sure. We could talk about that perhaps another time. That's an interesting question. But it appears that the LGI1 patients, you need to treat them for about a year or so. And then if you stop treatment after that kind of time, usually they don't relapse. A small number will. The Casper-2 patients appear a bit more refractory. They often need a bit more treatment and a bit longer treatment. So, and it doesn't seem to correlate nicely with the amount of time the antibody persists. So there's something else going on, right? There's something about the quality of the antibody or its affinity or its behavior that isn't as simple as its longevity. So it's a really interesting question you ask, and it draws lots and lots of interesting points for the future.
Thank you very much, I think. Sorry.
Yeah. Hi, Sarosh. It's Owen Flanagan here. Great talk, as always. Quick question. I've had some recent patients, and I noticed some reports in the literature responding to sodium channel blocker who was with lacosamide, which maybe is less liable to give a rash. Is there any sense of why that is? And then do you ever try that anti-seizure medication in LGI1? Rather than the ones that are more prone to rash, like oxcarbazepine or,
Yeah. So I basically now don't give these patients anti-seizure medications unless they've had generalized seizures, because the immunotherapy is definitely the best anti-seizure medication in these people because of the rash partly, but then also because you have to get them off the anti-seizure medication at some point, which at least in the UK and now in Florida causes problems with, say, driving and practical things like that. So that's the main reason I don't use those drugs. Why a sodium channel blocker like lacosamide should be particularly good, I'm not sure. I don't have a particularly good explanation for that. But I agree, some papers have suggested that it appears to be the most effective of them. So look forward to your ideas on that one.
Yeah, all right, thanks.
Thank you very much, Sarosh, for that excellent talk. And we move on to the next talk, and it's my pleasure to introduce the speaker, Professor Devanshu Dubey. Professor Dubey is the Professor of Neurology and Laboratory Medicine and Pathology at Mayo Clinic. He is also the Director and Medical Lead at the same institute. Professor Devanshu Dubey obtained his medical degree from Netaji Subhash Chandra Bose Medical College in Jabalpur, India, and he later completed his residency in neurology at the University of Texas, USA, after which he obtained a fellowship in autoimmune neurology at Mayo Clinic. So Professor Dubey is an enthusiast scientist in the field of central and peripheral autoimmune neurology and is actively engaged in both clinical and translational research. And he has contributed immensely to the discovery and validation of several novel biomarkers for autoimmune neurological disorders, including KLHL11, LUZP4 IgG, CAMIN4, and SCO2 IgG. And today he is going to talk to us on updates on paraneoplastic neurological syndromes and the latest diagnostic criteria. Over to you, Professor Dubey.
Thank you. Thank you for the invitation to talk. Sorry I couldn't be there in person along with Owen and others. It's very difficult to follow Sarosh actually precede Dr. Dalmau's talk. So I'm going to try to do this 30 minutes justice. I'm going to talk mostly about paraneoplastic neurological syndromes, but I'm going to touch on some of the novel complications of immune checkpoint inhibitors that we are starting to see, some of them which resemble paraneoplastic syndromes. These are some of my disclosures. So again, as I mentioned, I'm going to focus on discussing the new diagnostic criteria, which was put forward by a panel of people who actively are involved in clinical care and research for paraneoplastic neurological syndromes, led by the group in Lyon and on Dr. Graus and Dalmau, and also potentially highlight how some of these newer antibodies that some of which have been discovered at Mayo, other centers, are now starting to get utilized in diagnosis and management of paraneoplastic neurological autoimmunity. And then towards the end, we'll talk about checkpoint inhibitors because it's a fascinating window into pathophysiology of some of these paraneoplastic neurological disorders. And it's also sort of breaks some of the typical rules that we used to associate with antibodies and cancer associations or phenotypic presentations and so potentially antibody association in some case scenarios as well. The entity paraneoplastic neurological syndrome is not new. It's been around for a long, long time. Some of the initial reports came from Dr. Derek Denny Brown when he reported a case series or a case report of 2 patients. Interestingly, back then, you not only reported people, but also sort of included their job description, a boiler cleaner and a retired Army colonel, along with phenotypic characterization of a rapidly progressive, painful sensory ataxia. And exam findings were also suggestive that this sensory ataxia was probably related to a peripheral neuropathic process potentially affecting the dorsal root ganglia, which Dr. Brown subsequently confirmed by doing an autopsy study where he showed dorsal root ganglia cell involvement as well as some sort of dorsal column, probably retrograde involvement and injury as well. And both the patients, unfortunately, died of, hence the autopsy, and both were found to have an underlying malignancy without any metastatic involvement of the nervous system. This is when he sort of coined the idea that this could be a non-coincidental link between carcinoma and neuropathy, sort of starting the conversation or continuing the conversation about paraneoplastic neurological autoimmunity. Since then, I think in 2004, the first diagnostic criteria for paraneoplastic neurological syndrome came around. And since the field had moved forward quite significantly in the last 20 years, Dr. Honora, Dr. Grouse, and many others, including myself, met to review and update the diagnostic criteria which were put together initially back in 2004. Some of the main updates that were included in this diagnostic criteria was firstly change in terminology. Sort of learning from our epilepsy colleagues, sort of changing terminology is also something in fashion in autoimmune neurology. There will be also to make it potentially user-friendly. We changed the term classical syndromes to high-risk phenotypes, potentially highlighting certain phenotypes which are more suggestive of underlying malignancy, but also introduced a concept of intermediate risk phenotypes. These were some of the phenotypes which were not as well defined in the 2004 criteria, and more work had been done since then to suggest that these phenotypes, even though may not have as high as association with paraneoplastic autoimmunity, should also be considered, or paraneoplastic syndrome should be considered when you're encountering a patient with, for example, a tractopathy or a stiff person syndrome or a brainstem encephalitis. These are some examples of those intermediate risk phenotypes I'm going to talk about later. And then instead of using the term onconeural antibodies, what was suggested was let's use the term high-risk antibodies, high-risk paraneoplastic antibodies with a cancer association of more than 70%, and the intermediate risk antibodies with a cancer association of, let's say, 30 to 70%, and the rest will fall under sort of the low-risk antibodies. Some of the antibodies Dr. Rani were talking about, for example, LGI1 will fall in the low risk, Casper2 will fall in the intermediate risk, and some of the other antibodies, which I'll talk about, like ANA1, ANA2, will fall in the high-risk antibodies. And sort of to make things, as I mentioned, user-friendly, a composite score was suggested, which included categories or clinical scoring at 3 different levels. At a clinical level, a lab level, and a cancer level. What a clinical level included was what is the patient's phenotype. So this is what you would score when the patient comes to your clinic. The second part is probably scored once we get some of the test results back if the patient is positive for a particular antibody. And then the third part is often scored as the workup shows an underlying malignancy, or in some cases, as the follow-up shows an underlying malignancy. So that's an important point to remember in some of those high-risk phenotypes, high-risk antibody cases. It's important to do serial imaging, looking for cancer or cancer surveillance every 6 months up to a period of 2 years. And if that has not been done, patients were still getting 1 point, even if a cancer was not detected. And then in most scenarios, or nearly all scenarios, for a patient to have definite paraneoplastic neurological syndrome criteria, they needed to have an underlying antibody. The only exception was opsoclonus myoclonus syndrome, where sort of one defining antibody connecting the syndrome, especially in sort of pediatric populations with neuroblastoma, has not yet been sort of discovered, validated, widely accepted all across the world. The other benefit of sort of having now an updated diagnostic criteria was now we could utilize it to try and understand incidence prevalence of this disease at a population level. So this is a study that some of my team members did using our Rochester epidemiology project database, where we have clinical information or medical records of pretty much everybody who lives in that particular county. And sort of based on this data, we demonstrated that the prevalence of paraneoplastic syndrome is around 5.4 per 100,000 people. So about 17,000 individuals in the United States have paraneoplastic syndrome if we extrapolate those findings. So still a rare disease. But the important finding from the study was, even though the disease is rare, it causes a lot of disability. So we calculated disability using something called as disability adjusted life years calculation. And based on this study, what we found was the DALI associated with paraneoplastic syndrome autoimmunity kind of rivaled to common diseases like MS because of the severity of the disease and potentially the years of life lost due to the disease in many of these cases. So even though it's rare, still very significant and requires a lot of kind of commitment on our end to continue to kind of research and find better ways to treat these patients. So this is what I was referring to during my previous slide, where some of the categorizations for high risk, intermediate risk, and low risk antibodies were defined. Some of the antibodies at the bottom, which I put as with asterisks, were not antibodies included in the diagnostic criteria, but sort of potentially additions which might happen down the line as more and more literature builds around some of these antibodies, which tend to have a very strong cancer association. I'll start by talking about some of the high risk phenotypes. So these are the phenotypes where if you're encountering in your clinic, paraneoplastic neurological syndrome should be very high on the differential. So encephalomyelitis is one phenotype, which is a phenotype where the injury is happening at multiple levels of the neuroaxis. So it's not just sort of encephalitis. Some of these patients have coexisting myelopathy or myelitis, or in many cases, neuropathy as well, or encephalomyeloneuritis-like presentations. The typical cancer associated with this type of phenotypic presentation are small cell lung cancer, or in some cases, I've encountered patients with breast cancer and anti-physicin antibody also having a similar phenotype. Other phenotype examples were limbic encephalitis, rapidly progressive cerebral degeneration, opsoclonus myoclonus syndrome, like I mentioned briefly, in kids with neuroblastoma, but also in adult patients with various malignancies, especially in association with anti-Q antibodies or anti-Re antibodies. And then on the peripheral end, sensory neuronopathy, GI pseudo-obstruction, and Lambert-Eaton myasthenic syndrome. So I'll talk you through some of the examples of the patients I've seen in my clinic. So this is a lady who presented to us with progressive asymmetric numbness and gait instability. She had already had a bronch before coming to us and had a fine needle aspiration biopsy as a part of that, which showed this non-caseating granuloma. All this workup was sort of preceded by a PET scan, which had showed themselves some of the lymph nodes were lighting up. So that's why they were pursuing this additional invasive procedures. And as soon as they saw non-caseating granulomas, the first thought they had was this is sarcoidosis. So the patient was started on initially on low-dose steroids for a very brief period of time and then on infliximab. But unfortunately, the patient continued to go downhill. By the time she came to us, the EMG is on your right side, as you can see, clearly asymmetric loss of sensory nerve action potentials, suggesting potentially a sensory ganglionopathy localization. So as we often do in our clinic, when we're seeing patients and things don't make sense, the knee-jerk reaction, unfortunately, often is let's test for antibodies. And so we did in this patient's serum and CSF, and lo and behold, the patient came back positive for anti-physicin antibodies, both in serum and CSF. So at this stage, I took a step back, repeated the PET scan. It still showed lymph nodes, probably more lymph nodes lighting up than the last time they did a PET scan. But instead of doing a fine needle aspiration biopsy, we did wedge resections of 15 different lymph nodes. And interestingly, in majority of the lymph nodes that we dissected, we still ended up seeing a sarcoid-like reaction, but in about a half a dozen or more lymph nodes, what we saw was pathology consistent with breast cancer. So this is an example of sarcoid-like reaction, where the immune system is potentially trying to fight off and destroy the cancer, but in the process is seeing this amphiphysin protein in the cancer, leading to this friendly fire response, which is the pathophysiology of paraneoplastic syndrome, causing injury at the level of the sensory dorsal root ganglion in this particular patient. This led to sort of additional work in terms of understanding neuropathy presentation associated with amphiphysin autoimmunity. And we ended up identifying that a good chunk of patients with amphiphysin do have neuropathic presentations, even though the majority or the most common association, but when I think of amphiphysin, ends up in sort of, which is sort of most widely talked about, a stiff person syndrome-like presentation. Interestingly, in terms of phenotypic association, neuropathies tend to be somewhat slightly more common. Often, even in patients with stiff person syndrome-like presentations, or women with stiff person syndrome-like presentations, they have coexisting neuropathy. And some of the phenotypic presentations of neuropathy that we encountered was similar to that patient, a sensory neuropathy. Other neuropathy presentations included polyradicular neuropathy, sometimes with asymmetric onset, one leg being involved with pain and subsequently transitioning to the other side. When we talk about sensory ganglionopathy, I think the most important antibody here to keep at the back of our mind is ANA1 or anti-Hu antibodies. This is a review from one of my colleagues, Dr. Amato, which showed on an autopsy study where there's significant T-cell infiltration and destruction of the dorsal root ganglia, and in turn, there's also secondary injury in the dorsal column. And interestingly, in some of these patients, when you do an MRI of the spine, you do see some subtle hazy changes on T2 flare in the MRI. I suspect in many of these cases, these patients, this is primarily driven by dorsal root ganglia pathology, and you don't really see a lot of examination findings to suggest a coexistent spinal cord involvement. So that's just something to keep in mind as we try to localize the pathology in some of these cases. Another classic paraneoplastic phenotype, or high-risk paraneoplastic phenotype, I should say, is rapidly progressive cerebellar degeneration. And these are some MRIs. I wanted to include these because when we think about rapidly progressive cerebellar degeneration, especially in association with anti-Yo antibodies, patients presenting with sort of ocular movement problems, nystagmus, or significant dysmetria and ataxia, usually the MRIs look relatively normal early on in the disease course. But in really, really early phase, let's say within the first few months or 2 to 3 months of disease, if you're encountering some of these cases, we do see some meningeal or cerebellar enhancement potentially pointing towards the stage when actually if we start intervening, some of these patients might end up having much better outcomes than unfortunately most of my current PCA1 or anti-Yo paraneoplastic cerebellar degeneration cases. However, this doesn't last for very long, and subsequent imaging within a few months in these couple of patients that I'd seen showed that there was a resolution of enhancement, and then atrophy started to begin in some of these cases. There are other antibodies associated with paraneoplastic cerebellar degeneration, including amphiphysin, can have sort of cerebellar pathology. TRIM46 is another important antibody to remember, especially in association with neuroendocrine tumor. And as you can see, depending upon what type of antibodies we are seeing in this particular phenotypic association, can guide you where to find the cancer. So PCA1, amphiphysin, gynecological or breast cancers, TRIM46, amphiphysin, ANA1, small cell lung cancers, PCA-TR being lymphoma, or MAR2 or KELCH11 would point towards cancer germ cell tumors. Moving on from some of the high-risk phenotypes to intermediate-risk phenotypes, and many of these, as I mentioned, are newer additions to the paraneoplastic criteria, the 2021 one compared to the 2004 criteria, included brainstem encephalitis and anti-NMDA receptor encephalitis, Morvan syndrome, isolated myelopathy, stiff person syndrome, and polyradicular neuropathies. And I'll talk you through some of the examples of these various phenotypic presentations. Also, the antibody association with each of these phenotypes are different. So let's say if you're encountering a patient with brainstem encephalitis, potentially thinking about testing for Kelch11, MAR2, antibodies like leucine-4, anti-RE, or TRIM46 is very important. Similarly, polyradicular neuropathy is another sort of unique phenotype, as I mentioned, can have an asymmetric sensory motor predominant presentation, sometimes associated with neuropathic pain and dysautonomia, starting off on one side and then transitioning to the other side, which also has a unique cluster of antibodies. So I'll talk about this particular patient of ours who 41-year-old gentleman who presented with right-sided tinnitus and sensory neural hearing loss. The same exact story, unfortunately, I've seen now in about a dozen cases where all of these patients will have a very unique presentation. This particular individual, along with sort of sensory neural hearing loss starting from the right side, started developing some intermittent dizziness, again, suggesting to a peripheral process, at least at the beginning. Went to the ED, was given a diagnosis of viral labyrinthitis, given a short course of prednisone and acyclovir, sent for vestibular rehab. Interestingly, partially the tinnitus and the hearing loss did improve, but it did all of it came back. And 5 months later, he developed diplopia, nystagmus, ataxia, suggesting whatever that peripheral process was now was sort of transitioning to more of a central cochlear vestibulopathy or central brainstem syndrome. Testing was done. MRI initially came back to be normal, but the CSF studies clearly suggested an immune-mediated process. Back then, the GQ1B antibodies and some other antibodies, including infectious serologies, were tested, which all came back negative. And we did not know often the name of the protein this particular antibody was binding to back then. This is on the right side, you can see an audiology clearly showing the patient had significant asymmetric hearing loss. What we did end up seeing was the unique staining pattern, which we used to fondly refer to as sparkles, where there was small dotted staining across in the region of the murine ventricles on the tissue immunofluorescence staining. So you can think of this particular image as thin sections of mouse brain with patient's serum and CSF added on to these thin sections. And then what we are seeing is the patient's antibodies binding to certain structures, certain areas of that mouse brain. In this particular case, looking at those dotted starry sky kind of pattern, which we used to fondly call as sparkles. Even though back then we did not know the name of the antigen, we already knew the clinical phenotype and the cancer association. And then subsequently through work with our colleagues in UCSF and using a technique called the phage display, we ended up identifying the antigen, which was Kelch11. So even before the Kelch11 reporting in this particular patient, we had done a scopal ultrasound looking for cancer, which came back negative. But doing a subsequent PET scan showed there's something lighting up right next to the heart, which on biopsy was confirmed to be germ cell tumor or seminoma, as we were suspecting. This particular patient, in addition to removal of the seminoma, underwent aggressive immunotherapy with cyclophosphamide for an extended period of time. Even though he still has gait instability, still has hearing loss, the right-sided hearing loss never recovered, we were able to stop the disease from progressing. And he was able to go back to his highly demanding job as a physician. So there are some cases where sort of intervening early and intervening aggressively during the early phase has provided sort of stability in many of these cases. And in rare cases, some improvement as well. So there are about 2.8 per 100,000 Kelch11 patients among men, based on our epidemiology study, again, similar to sort of the data it suggested or showed for the paraneoplastic neurological syndrome. Most of these patients tend to have a rhombin encephalitis, brainstem predominant phenotype, sometimes spilling over to involve the cerebellum as well. And there are some patients that I've encountered lately with a seizure presentation, but even at the time of seizure presentation, which suggests a limbic involvement, over time they do end up developing nystagmus, ataxia, or other features as well. But if there's one thing to remember in these patients, so how to capture them early is to keep an eye out for any peripheral cochlear vestibular dysfunction, especially hearing loss or tinnitus, as that precedes the brainstem involvement by months in many of these cases. Most common underlying malignancy ends up being sort of underlying seminoma or germ cell tumor. These are a couple of my patients. I think the first patient is Dr.
And if you want to hang on to her hand, perfect. Now show your own pace. And please tell.
Walking difficulty, not a classic cerebellar gait. Sort of in some of the other cases I've seen where it becomes more rapid, it's sort of more of a mix of a PSP-like gait with sort of cerebellar features. Some of these patients, like this one, unfortunately, the syndrome hit the breathing center in the brainstem, and he developed something called as Ondine's curse and was unable to breathe when he went to sleep. So we had to kind of put a tracheostomy. He also ended up developing trismus, and he was unable to open his mouth because of that.
Say, the president lives in the White House.
The president lives in the White House.
Today is a nice day.
Today is a nice day.
Can you open your mouth? Say yeah.
Just a couple of examples of these cases. Unfortunately, relatively young, mostly men, and mostly with underlying seminoma. Seminoma ends up being the least of our problems because in most of these cases, stage 1 or potentially in some cases stage 2. But the disease itself, the damage to the brainstem or cerebellum, ends up being pretty significant, but oftentimes irreversible. We've done a considerable amount of work, both in pathology as well as sort of in the lab, to try and understand the disease. Some of the initial work we did working with Dr. Giannini in looking at the brain pathology, we could tell that there's a significant amount of inflammation with sort of appearances, which again remind us of that initial side showing sort of sarcoid-like picture with significant macrophage T cell deposits in sort of granulomatous form. This is not the only case. I've had a couple more cases with similar pathology picture. I know Dr. Gelfand, I was talking to in UCSF, he's had a couple of cases as well, potentially suggesting the pathology of Kelch11 might be slightly different from some of the other classic herniaplastic cases I've sort of reviewed, including some of the Anna 1 or Hugh cases or autopsies. We working with our colleagues in translational immunology lab, we've also demonstrated that when we take PBMCs from patients with Kelch11, introduce the Kelch11 protein, allow the APCs to kind of chew up the protein and present to the T cells, there's clear activation of both CD4 and CD8 T cells. And when we do slight-off studies, the subset of T cells that we see activation in belong to that memory cytotoxic T cell lineage, sort of potentially giving us some insights into disease pathogenesis. Unfortunately, majority of the patients we were seeing up till more recently are coming to us at this particular stage where the neurons were already destroyed or changed into sort of fibrotic regions, potentially not allowing any room for recovery or improvement. With the test now being available, more and more patients are being diagnosed early. Even in the last 2 months, I've had 2 patients with predominantly hearing loss pathology at this stage with minimal brainstem pathology, potentially giving us more hope that we might be able to stop the disease at a much earlier time point in many of these patients now. Learning from this sort of these discoveries related to germ cell tumors and then transitioning and making our own in-house phage display, we've started venturing into using phage display to study antibody signatures in various cancers. So some of the work that we've done in germ cell tumors has clearly demonstrated that actually antibodies not only cause paraneoplastic syndrome, they also help us sort of a theory which has been around for probably more than a century, that the humoral response and the cellular response allows us to protect us from cancers. But we are harnessing this response to study and diagnose and prognosticate various cancers, starting from germ cell tumors, venturing into other cancers as well. And surprisingly, these antibody signatures tend to perform markedly better than any of the existing traditional markers, and sort of giving us insights into not only how to diagnose these patients, but also some of these prognostication potential therapeutic windows for some of these refractory cancers. Germ cell cancer, specifically seminoma, not being a refractory malignancy, but some of the teratomas, and then distinguishing seminoma from teratomas and some of the other cancers. These techniques that we've developed for discovery of autoimmunological disorders are coming in really, really handy. Another manifestation that sort of we briefly touched on in the paraneoplastic diagnostic criteria was peripheral hyperexcitability. I put these couple of videos to suggest that the peripheral hyperexcitability can be either at the level of the nerves, as Dr. Irani showed in a particular video, but it could also be at the level of the muscle. So our first patient is a patient with thymoma with diffuse who came in from muscle cramps and sleep changes and insomnia. With hyperexcitability at the level of the nerves, if we stick the needle or do an EMG in this particular patient, we would hear myoclonic discharges or neuromyoclonic discharges. Whereas the second patient, who also had a thymoma, came in with muscle rippling, which is also a form of sort of potentially hyperexcitability. If you talk to one of my colleagues, Dr. Leji, he thinks it's sort of a different phenomena where there's sort of a loss of inhibition of excitability, which is what ends up being the cause. These patients, some of these patients do have underlying malignancy. The first patient ended up having an antibody Casper-2, as was discussed in the last lecture, and this patient on the right side had an antibody called Cabin-4, which we discovered a few years ago. We've had other patients with breast cancer and sort of Cabin-4, paraneoplastic autoimmunity, and some other cancers as well. Interestingly, based on some of the work that we've done with IHC, transcriptomic studies, there's clear depletion of Cabin-4 in a patchy distribution from the pathology of the patient muscles in a distribution similar to the loss of caveolin-3, which used to be the hallmark or how to diagnose these patients in the past. But in patients with caveolin-3 mutation who can present with rippling, genetic form of rippling muscle disease, we don't see Cabin-4 loss. We don't see Cabin-4 loss in other pathologies like dermatomyositis, as you can sort of, or other muscle diseases, suggesting it's a very specific loss of protein without a lot of T-cell infiltration, potentially suggesting towards sort of a direct effect of antibody in this particular cohort. Another peripheral manifestation that can have or often does have a paraneoplastic basis are patients presenting with polyradicular neuropathy. This is one example of a patient who came into the ER with pain, asymmetric lower extremity weakness. You can see unfortunately the abdominal contents protruding because of laxity of the abdominal wall muscles. In this particular patient underwent nerve biopsy, specifically a fascicular nerve biopsy. Sort of we identified a more proximal nerve and then did a fascicular sectional biopsy, which showed significant inflammation, T-cell cuffing. Antibodies did result potentially after the biopsy had also already been done and came back positive for an antibody called as CRIMP5. So this is an antibody which has been around for quite some time, discovered around the same time by our colleagues in Lyon, as well as by Dr. Lennon at Mayo. What we know about this antibody is it is commonly associated with malignancy. The two cancers we usually think about with this particular antibody are small cell lung cancer or thymoma. Therefore, this patient underwent a PET scan, which showed sort of areas were lighting up in the para-aortic region, which on biopsy confirmed mixed small cell and non-small cell lung cancer. Neuropathy is the most common phenotype encountered in patients with CRIMP5 paraneoplastic autoimmunity. The most common phenotypic characterization of neuropathy was similar to this particular patient, although most patients may not be as severe as this one. But most of the common phenotypic association that we encountered was asymmetric polyradicular neuropathy. Sensory ganglionopathy, like the first case I had shown, the lady with breast cancer and amphiphysin, that's another phenotype to keep in mind with CRIMP5 autoimmunity. And then as I'm coming towards the end of the paraneoplastic part, I might suggest show some of the very recent study that published just a few weeks ago. But the work on this had been done more than 2 decades ago when Dr. Lechance identified, sort of playing Sherlock Holmes, more than 24 workers working in a spam-making factory or a pork meat processing plant who were coming to him with this very peculiar type of neurological illness with a very neuropathic predominant presentation, which on sort of, in hindsight, with clinical characterization was characterized as polyradicular neuropathy. These patients were seen by Dr. Dick, who did a lot of the EMGs, the phenotypic characterization, in many cases nerve biopsies, and then Dr. Lennon had done some of the initial tissue immunofluorescence work, which showed this very unique synaptic staining pattern. Interestingly, back when all this was being done, these patients were also positive for antibodies to voltage-gated potassium channel. Back then, there was sort of still the data supporting that VGKC is not as useful, was still limited, and the growing LGI1 Caspar-2 were not being utilized in clinical practice. And that's why the story just stopped there. So when I joined the lab, we already had sort of learned that these patients were negative for LGI1 and Caspar-2, suggesting this unique staining pattern was potentially suggestive of something else, some other neural synaptic antibody. So we utilized this technique that I had mentioned before called phage display, and I ended up identifying the two novel proteins, synaptophysin and GAP43, both belonging to synaptic vesicles, to which these patients were making antibodies. Interestingly, the most interesting part was the patients who were positive for synaptophysin and GAP43 or synaptophysin or GAP43 had a very peculiar presentation, I had mentioned, with a polyradicular neuropathy presentation, which was consistent on nerve biopsies showing mixed axonal and demyelinating features with sort of significant inflammation, especially around some of the microvessels in the epineurium. We ended up identifying a large cohort of a similar presentation who were negative for all known antibodies, but were characterized to be immune-mediated based on the clinical course, treatment, etc. And when we tested this large cohort of antibodies, we ended up finding more than a dozen patients who were positive for these antibodies as well. And these patients were never exposed to aerosolized pork brain, or never in even close proximity to a meat packing plant, suggesting these antibodies, which were secondary to an environmental exposure, can also occur due to other triggers. And some of the patients that we ended up identifying with this other neuropathy presentation, which we call inflammatory polyradicular neuropathy, had underlying cancers, small cell lung cancer being one, others having hematological malignancy, again, bringing us back to a paraneoplastic trigger for some of these cases. Moving on, sort of from the classic paraneoplastic syndrome to now briefly touching on checkpoint inhibitors. So this gentleman came to our clinic, to our neuromuscular clinic, to see us for a question for second opinion about myasthenia gravis, a refractory MG following checkpoint inhibitors. He was started on Folfox and nivolumab, and within 2 months had developed vertical diplopia and dizziness and sort of head motion-induced disequilibrium. MRI brain was normal. He was treated with short course of prednisone with some mild initial improvement, but then started getting worse again. For some reason, myasthenia was suspected, and he was started on myastinol. This is his examination. So even just on an initial look, you can start seeing wing beating tremors, something I've never seen in MG. I doubt anybody has. But in addition to that, when we did further testing, including electrodiagnostic study evaluation, there was no evidence of neuromuscular junction defect. There was some mild neuropathy, probably related to prior chemotherapy. But our examination was very vivid, very clear, suggesting sort of a brainstem/cerebellar pathology, along with sort of wing beating tremor. There was evidence of ataxia on examination, requiring a walk for ambulate. At this stage, again, I think we did a more comprehensive antibody evaluation, and to our surprise, he ended up having that antibody I was referring to and talking about, which is typically associated with germ cell tumor, Calc11. We ended up taking the tumor out and staining the tumor for Calc11 and demonstrated that his esophageal cancer, for which he was getting the checkpoint inhibitors, had marked expression of Calc11. This is not the only case of atypical cancer association. There have been sort of the literature filled with multiple reports, including studies from our group and Leon and many others, showing how in the setting of immune checkpoint inhibitors, often the typical cancer antibody associations we think about are not necessarily seen. There have been many cases of patients with melanoma with an NDA receptor antibodies, or like this one, Calc11 esophageal cancer. So in that particular setting, when I'm seeing patients in the inpatient setting with ICI, encephalitis, I tend to order a more comprehensive antibody evaluation driven primarily by the neurological phenotype. A meta-analysis done by our European colleagues also demonstrated that in patients with ICI related encephalitis, the things which influence the outcome or response to therapy or prognosis are firstly the type of cancer. So the more traditional cancers associated with paraneoplastic autoimmunity, such as small cell lung cancer, tend to do worse. The type of encephalitis, so if somebody has limbic encephalitis, which is a high-risk paraneoplastic phenotype, or has extra extra limbic encephalitis, or let's say diencephalic involvement, like has been reported in some of the MAR2 cases, those patients tend to do worse compared to some of the meningitis cases or meningoencephalitis cases without a lot of parenchymal involvement. And then presence of what used to be called as onconeural antibodies, or what is now referred to as high-risk paraneoplastic antibodies, like anti-Hu, CRIM5. Some of these antibodies tend to have worse association, potentially suggesting a difference in the pathophysiology of some of these ICI-related events, which resemble paraneoplastic syndrome and share potentially pathophysiology with paraneoplastic syndrome as well. And this is not just limited to the central nervous system space. We've done some work in the neuropathy space, again showing neuroendocrine tumors presenting with sensory ganglionopathy.
Professor Dubey, sorry to interrupt. I think we have exceeded time. Could you please finish your lecture? We have exceeded time.
I will just go to the last slide then. So I think, as I sort of mentioned in the talk, most of this talk is focused around the new paraneoplastic diagnostic criteria and then some of the updates related to the paraneoplastic diagnostic criteria. I would highly recommend potentially going back and reviewing the PNS score. I find it extremely useful in clinical practice. Using the criteria, we've demonstrated that as epidemiology of the syndrome and some of the more traditional biomarkers like Hu, PCA1 still continue to be extremely important in clinical practice and tend to be the most common antibodies. But there are newer antibodies like Calc11, which are being sort of utilized more and more in clinical practice. And then lastly, in terms of checkpoint inhibitors, we're starting to see more and more cases, some of them resembling paraneoplastic syndromes, both in terms of outcome as a phenotype and outcome. And this is my last slide, and this is our neuroimmunology lab, and then my research team on the left and some of my key collaborators. Thank you.
Thank you very much, Prof. Dubey, for that comprehensive lecture and very, very exciting news. I'm sorry we won't be able to take questions because we are way over time. So let us move on to our next speaker. It gives me great pleasure to introduce Professor Joseph Dalmau. Professor Dalmau is an internationally renowned neurologist and neuroscientist, best known for his pioneering work in autoimmune encephalitis. So he is one person who has actually revolutionized autoimmune neurology with the discovery of the NMDA antibody encephalitis, and thereafter a cascade of other antibodies and autoimmune diseases. Professor Dalmau initially worked in Barcelona, and then he moved into the University of Pennsylvania, where he was professor of neurology for 23 years. He has now moved back to Barcelona, where he is the professor of neurology at the hospital clinic in Barcelona. He's also the adjunct professor at the University of Pennsylvania. He has received numerous awards, is a member of the National Academy of Medicine and several other scientific societies, and is the associate editor of Neurology, Neuroimmunology, and Neuroinflammation. So we are privileged to have you at this symposium. Over to you, Professor Joseph Dalmau, who will be speaking to us on Beyond Autoimmune Encephalitis, Broader Neurological Insights and Cross-Disciplinary Lessons.
Well, thank you very much. I hope that you can hear me. Can you confirm that you can hear me?
Yes, we can hear you.
Yes. All right. So I'm going to share the screen. See if I can do that. Can you see the screen, please? Can you see my first slide?
No, no.
Okay, let me start again. Can you see it now?
No.
Can you see it now?
No, no.
No? Okay. I'm having problems with the double screen. And now?
No, sorry, no.
Let me start all over, okay? I'm going to connect again, okay?
Right, okay.
So we can see you.
Can you see me now? Yeah, okay, let's see. Sorry about that, usually works, but
Yes.
Can you see now the slide?
Yes, yes, we can see.
Yes,
okay,
we can
well,
see
thank you. Sorry about this star. Well, first of all, I would like to thank you for the invitation to be there. And unfortunately, I cannot be there in person. The goal of today, I prepared this presentation to be relatively short. The goal of today is to address two concepts that I think are important in the field. One is to consider the autoimmune or the antibody-mediated encephalitis. These are a little bit different from the previous talk, in that in here the antibodies appear to be pathogenic, that these are nosological entities, that are basically independent nosological entities, and then how they have influenced other areas of not only neurology, but outside neurology or beyond neurology. So I would like to start with an example here. Let's imagine the field of autoimmune demyelinating diseases, and you see here and the NMO and the discovery of aquaporin 4, the MOC IgG in these years. This basically prompted a fundamental reclassification of the inflammatory white matter diseases. In fact, they establish these as different nosological entities with unique pathophysiological mechanisms, clinical phenotypes, and even therapeutic requirements. So basically, most of hospitals were prepared to integrate these diseases in the clinical practice because in most of them they have a specialist on multiple sclerosis. And nowadays, basically, the idea of publish a manuscript mixing all these disorders would be methodologically unsound and unlikely to progress beyond the editorial triage. Now, this scenario differs very much from this antibody-mediated encephalitis, which now there are basically 17 of these disorders, right? And unlike the ones of the white matter disease, these were not really integrated in a single department, in a single section in the hospital. The first physicians in seeing or try to integrate these were physicians working in paraneoplastic syndromes. And now with the autoimmune neurology specialty emerging, of course, they are seen by them. So many times first of all, these diseases many times are not recognized initially as autoimmune, and then they are admitted to different areas of the hospital or specialists that or align with the main symptom that brings the patient to the hospital. So in this context, aggregating all these diseases remain common and uncritically accepted. So there are many papers in that they talk about predictors of autoimmune encephalitis, in that, for example, all of them are mixed. You can look at the literature even now and you're going to find them. And this is as methodologically flawed as combining MS with NMO spectrum disorder or MOGAD. So today, I want to focus in these three diseases here, some way emphasizing some of the differences, and some moments of the disease, I would say, in the course of the disease that particularly interest me quite a lot. So let's just start with the first one, with the NMDA receptor encephalitis. It's a complex disease that's summarized in a single slide. And I'm going to focus mainly in this part here, which we call the post-acute stage or the recovery phase, although probably the disease is active here, as well as in this area here. But just to remind all of you, this is a disease that can present with a viral-like syndrome, as many autoimmune encephalitis and paraneoplastic syndromes. They can present sometimes like a viral-like process, despite that there is no virus involved. And then in this particular disease, there are prominent psychiatric symptoms at the beginning, particularly in adults or in adolescents. There is worsening, and many patients need to be in the ICU with multiple complications, dyskinesias, dysautonomia, and seizures and other complications, and then there is this long process of recovery of this post-acute stage. These arrows represent a study that we did here. We are still doing this study here in Barcelona, and that the patients in this stage, when they can travel to Barcelona, they come, and in 1 year they are visited 3 times, and they undergo a lot of studies: neurological, psychiatric, multiple paraclinical tests, etc. It's interesting that in this study, when the patients are considered that they are quite well, because they are, of course, not longer in the ICU, they can travel. In visit 1, which means several months after the disease onset, just basically only 10% of the patients had completely normal cognitive functions with all these cognitive domains, only 10 at visit 1. And at visit 3, of course, these patients have improved, but there are still basically 40% that they have multiple cognitive domains affected. And these are the cognitive domains of the areas more affected. And you can see the improvement in most of them, but the working memory is the one that patients this gets stagnant there, and most patients remain with cognitive problems, mainly in the area of working memory. In the same study, we compare the patients. This is a prospective study. It's still ongoing on. And we compare patients also prospectively with the control group, age and sex match control group with patients with stabilized schizophrenia. And what you see here is basically that the cognitive and also the psychiatric evaluation that is not shown here is very similar to patients with schizophrenia, with patients with NMDA receptor encephalitis. Again, in this process of recovery, remember, this is when the patients are in this phase of recovery. And you can see here that as time goes by, schizophrenic patients remain the same as the beginning all the way, and the patients with an NMDA receptor encephalitis start improving and moving towards the direction of the healthy individuals. But after 1 year, there are still many patients that they have still these cognitive deficits that persist. So this gives a profile of cognitive alterations in patients with NMDA receptor encephalitis. And the bottom line here is that the faster recovery is during the first 6 months, and this is probably a window of time to improve or to implement some sort of cognitive training in improving this or even prolonging immunotherapy. Now, with LGI1 encephalitis, a similar study. I'll show you in the next slides a similar type of approach. But remember that this is a disease that's often about 40% of patients present with focal facial-brachial dystonic seizures, focal seizures, with memory more on the difficulty in forming new memories rather than working memory, although it's also affected. And then patients get treated with immune therapy. There is basically a faster improvement that patients with an NMDA receptor encephalitis and usually improve. They go close to normality, but many of these patients remain with also alterations. When we did a similar study here, also visiting these patients for 1 year in 3 visits, the surprise was that it was very different from NMDA receptor encephalitis. And here also, in the first visit, this is visit 1, in the first visit, all the patients have at least 1 or more, many actually 5 or 6, of these symptoms, right? So all of them, when they came several months after the presentation of the disease. And in here you can see how they evolve, they are improving. And here 30% of the patients did not have any of these symptoms. Now, when we look at the symptoms here, this is the evaluation of cognitive impairment. Now, the cognitive impairment here is a little bit the profile different from NMDA receptor encephalitis. In here is more memory involvement, more than the profile of the working memory that I showed you before. And here is more visual verbal memory and more in the area of hippocampal dysfunction, although of course working memories can also be affected. And what the profile of psychiatric alteration is also much different compared with NMDA receptor encephalitis. The surprise in this study in that the patients underwent extensive evaluation and also video polysomnography, which means that the patients for 12 hours were completely, were recorded and completely followed then with video. The interesting thing is that still patients several months after the initial presentation, still have facial-brachial dystonic seizures. And this is the only symptom that after 1 year, basically, there was the only symptom that was that disappeared, that was controlled. And then in terms of focal onset seizures, also there was an improvement, but the patients that developed hippocampal sclerosis then developed again focal onset seizures. And the most important or remarkable finding was the sleep dysfunction that was very, very different from NMDA receptor encephalitis patients, in that in here, and the REM sleep behavior, most patients have alterations of REM sleep and REM sleep behavior disorder. And in this study, what showed is that many times when the patients come to you, apparently recover, that they, when you ask them in the outpatient clinic if they have still focal onset seizures or they have facial-brachial dystonic seizures or anything that resembles seizures, they deny that. Even the primary care physicians that take care of them, even they are not aware of these. But actually, when you do video polysomnography, what you see at night is actually there are still many focal onset seizures, and sometimes mixed with facial-brachial dystonic seizures. And all of these are examples of each histogram here is actually a recording of a patient. And sometimes what you have is these mixed facial-brachial dystonic seizures, what's called wake after sleep onset, which is quite prolonged. So in here, this is a study what showed if you compare this with an NMDA receptor encephalitis in this phase of recovery, the NMDA receptor encephalitis patients basically don't have prominent sleep alterations, and the architecture of the sleep is basically normal in most of them. But this is very different from the LGI1. So these are, as I mentioned at the beginning of the talk, completely different nosological entities, not only mechanistically, but also in terms of the presentation of symptoms and also in terms of the post-acute or the long-term follow-up of these patients. And then the third disease, this is even more different. This is a disease that was identified here by our colleagues specialized in sleep, that here in Barcelona are in the Department of Neurology. And what you see here is a patient that in this stage of the sleep, he should be basically paralyzed. They should be not moving at all and have all these movements. And the patient is asleep, is not awake, okay, but have all these what's called phenolystic movements. These patients have this antibody against a protein called IGLUN5, and there is a very strong HLA association. And the presentation of this, or the core syndrome of this disease, core alteration of this disease, of this complex parasomnia, which is what led to the discovery of this entity. But the patients can initially present with several different types of clusters of symptoms. Sometimes like movement disorders is very, very frequent. In fact, is the disease and have more movement disorders, even more than NMDA receptor encephalitis. And this is very rare presentation with a supranuclear gaze palsy-like type of syndrome. Very common is presentation with bulbar symptoms and dementia and chorea. The dementia is usually very mild at the beginning and during the course of the disease. So these presentations usually progress towards the core syndrome, that is the sleep alteration, and the REM and non-REM parasomnia. This is the core syndrome. And then when these patients die, these patients don't go very well in terms of prognosis is much more serious than patients with other types of antibody-mediated encephalitis. What you find here is these deposits of tau. This is mainly R4 tau, isoform of tau, in the dorsal part of the brainstem and in the hypothalamus. So the question initially was, this is autoimmunity was causing neurodegeneration, neurodegeneration was causing autoimmunity, and there were factors in favor of one or the other, but nowadays it seems that is the autoimmunity which leads to neurodegeneration. This has been shown elegantly by Ellen Gelpi and Romana Hopberger in Vienna, that used to be here with us. These are both neuropathologists training in autoimmune neurology. And what you see here is that actually at the beginning of the disease, the patients that die in the earlier stages, these patients usually die of brainstem dysfunction, complications of dysphagia, bronchopneumonia, etc. You actually find inflammatory infiltrates, and there is this high expression of MHC class 1. And also there is this microglial infiltration. What you see here, all of these, all the stainings here are the deposits of antibodies that are IgG4, all these stainings in the brainstem, in the cerebellum. And these, you can see that colocalize very nicely the deposits of the antibody with the expression of IGLON5. So the idea nowadays is that these diseases start mainly with inflammation at the beginning, not too much, but as time goes by, there is these deposits of tau in this particular distribution that I mentioned before. And also these antibodies cause an irreversible internalization of the IGLON5. This is a control neuron exposed to control CSF. And these are neurons exposed to the CSF of these patients, and you can see this internalization of the IGLON5. There are much less clusters, fewer clusters here than in here. And this internalization associates with this alteration of the neurofilaments that should be very, nice and thin, and as you can see here, instead they have these alterations of the cytoskeleton that probably leads to deposits of tau. This is very different because these alterations I mentioned are irreversible, and this is very different from, for example, an NMDA receptor encephalitis or LGI1, in that the antibodies cause this internalization of the receptor, of the NMDA receptor, of this disturbance of the LGI1 protein, but these effects are reversible. And I want to finish my talk with a few comments about how instead of viewing the field of autoimmune encephalitis from the eyes of neurologists or you like specialists in neuroimmunology, is that how these diseases have impacted other fields, other specialties. And I don't have time, so I want to talk only about the pediatrics, but I have slides prepared if there are questions about epilepsy and psychiatry, but I want to talk only in pediatrics and of intensive care. In pediatrics, this is a study that was published the last year, the autoimmune encephalitis, and of course, autoimmune diseases of the white matter has had a big impact in the field of pediatrics. This is a study of 729 children. This is a prospective study with a median follow-up of 3 years. And not only these ones, but all patients were followed prospectively, and the information was followed, and with the final diagnosis in all of them. Okay, so the point here is that basically in children, basically when you suspect autoimmune encephalitis, basically you are going to be right in 1/3 of the cases. And in here, there are a group of diseases with antibodies, another one without antibodies, like would be most toxoclonus myoclonus in this area here, and some other type of disorders. And now in children, what is important is that most antibodies, and you can see here these 150 here, most of them are either NMDA receptor, or MOC. So in children, the panels, if you had a panel only of 2 antibodies, you would probably identify most of the autoimmune encephalitis, not all, but most of the autoimmune encephalitis in children. This is an area also, this slide represents an implication or impact in pediatrics, in adults also, but in infectious diseases is that the study of these autoimmune encephalitis have in some way put a name on etiological cause of what used to be called chorioatetosis post-herpes encephalitis. This slide what shows is that patients with herpes encephalitis, PCR positive, if you study them at the beginning, they don't have antibodies. Not at all. I mean, you can, if you do the study prospectively, you find this. Herpes encephalitis, of course, the PCR is positive, no antibodies, but basically in about 50% of patients, when the acyclovir is discontinued, they have antibodies against neuronal proteins. And of these 50%, 25 of these, no, the whole entire series of half of these 50%, half of them develop symptoms of encephalitis. But this time, this encephalitis is antibody mediated, it's no longer caused by the virus. The PCR here is already negative. If the patient is younger than 4 years, almost always have chorioatetosis. If the patient is older, they have more profile of symptoms like anti-NMDA receptor encephalitis, or behavioral and psychiatric alterations. These autoimmune encephalitis, post-herpes encephalitis, often associates with NMDA receptor antibodies, but can associate with a mix of antibodies or other antibodies. And I want to finish with a recently completed study that in some way fascinate me, because this part here, actually this part here, there is, all right, in the NMDA receptor encephalitis patients, about 80% have final relatively good outcome, okay? So, but there are a subset of patients in that they get stuck with alterations of consciousness for months. And this always interests me very much because it's difficult to understand what to do. And criteria in terms of these patients are responsive, not responsive to treatment, etc. So we did a multi-center retrospective study since we identified the disease in 2005. And this is quite unique because the criteria that we selected was very extreme. It was a study patients that had been in vegetative state, stuck here, for more than 9 months. That was the inclusion criteria. And the outcomes was death, common following, MRS score of 2, or full recovery. And this is a summary of the study. We identified 45 patients over the years that have been more than 9 months in the ICU with vegetative state, what's called also as unresponsive, awake but unresponsive. 38 females, and some way the profile was very similar to the classical NMDA receptor encephalitis, all were treated with first-line immunotherapy, 91% with second line, that means rituximab mainly, and 40% third line, that means whatever people use when rituximab is felt that is not working. So these are the numbers. Again, it's quite extreme. 399 days, there was the median time in vegetative state, the ICU, median time 275 days, mechanical ventilation 270 days, hospitalization 474 days. Here is the surprise. 62% of the patients improved, and 32% have full recovery. Full recovery, what it means? It means that the MRS was 0, the modified ranking scale was 0, and the patient were able to go back to their previous activities, full activities, 1/3. 13% of the patients died, and 24% had, at the end of the study, MRS 3 or 5. Now, these were extreme cases. There were like 13% of the 13% of the patients that had cardiac arrest, sometimes more than 3 cardiac arrests. They were resuscitated, of course, all were in the ICU. Nobody died of the cardiac arrest. So conclusions, this is a study that has many, many implications, but here I'm going to read some of them before going to the last slide. Prolonged disorders of consciousness should not be equated with a reversible brain injury in an MDA receptor encephalitis. This is important, okay? Because in many places, when the patient is in the ICU and doesn't improve in 2 weeks, everyone gets nervous. So that's not should be the case in this particular disease. Current definitions of treatment refractoriness underestimate the delayed and slow response to treatment. So many, well, there are not so many, but some of the improvements credited to third-line therapies, in our opinion, are delayed improvement of second-line therapies, or even sometimes spontaneous recovery. The timing for declaring therapeutic futility remains undefined and should not rely on the experience from other conditions. And this is in cases of refractory to first-line therapies and rituximab, third-line agents are not convincingly demonstrated efficacy or superiority to cyclophosphamide. We don't use these ones. We use a lot cyclophosphamide. This is just an example, an extreme example of one of these patients, in that this is the only patient that actually is one of the initial patients. By the time of discovery of the disease, in some way the diagnosis was not done for 1 year. And the patient was in the ICU with vegetative state and so on. So as soon as the patient was diagnosed, because it was moved to another hospital, the teratoma was removed and received immune therapy, and the patient improved. Another point of this study that I show you is that patients can be for vegetative state even for a long time and still respond to treatment. So these are the treatments usually followed in these diseases, in autoimmune encephalitis in general. This is inspired in some way by this study of Titular that we published in 2013. First-line immune therapy, here you have them, second-line rituximab and cyclophosphamide, and third-line. But I'd argue for many different reasons that many of these patients respond to first and second line, or even spontaneous improvement, and the effects of these treatments are quite need clinical trials. Many times I'm not convinced that some of them represent that they have clear effects, but the effects that you are seeing are late effects of rituximab and cyclophosphamide. So the conclusions are that the autoimmune encephalitis should be viewed as distinct nosological entities, so each one different from the other one. I think that these studies, in that they mixed all together, sometimes even with the GAT thrown there, or with the voltage-gated potassium channels, and they make a combo, and then they publish of the prognostic factors and so on. All these studies, they are basically not relevant. They don't change anything. Actually, they complicate things. So they are different nosological entities and should be different, considered different, the same as MOGAD versus neuromyelitis optic spectrum disorder. The post-acute stage presents a bridge to long-term deficits and a window for intervention. This was what I presented with an MDA or LGI1. And the heterogeneous presentations of all these diseases and has involved other disciplines beyond neurology. And these emphasize that basically we have to strengthen this interdisciplinary communication, pediatricians, psychiatrists, intensive care doctors, etc. And these are, well, this is the conclusion slide in some way, the finished slide showing the centers where I'm working now here in Barcelona, and all the people involved in some of these studies, and including Ellen and Romana that are currently in Austria. Thank you very much.
The presentation is open for any questions.
Hi, Josep, this is Peter Hartung. Greatly enjoyed your thought-provoking talk. I have just a very basic question, and just demonstrating that this is really not my field. I mean, it's been talked about these conditions being autoimmune in nature for decades. Are there any of those in which the Koch-Vitebsky postulates of autoimmunity have been conclusively shown? I mean, transfer into animals. And are there animals for any of these conditions? Animal models.
Hi, Peter. Yes, it's good to see you. Thank you for the question. Yes, for many of these, that's a very good question. And recently, there was a review that we published. I think was in Current Opinion in Immunology, and we review all these diseases and the models that there are. So for all these 17 diseases that I mentioned that are antibody mediated instead of antibody associated, which basically the antigens are on the cell surface of neurons, for all of them, or for most of them, the antibodies have been shown to be pathogenic or cause alterations, more than pathogenic, cause alterations in the protein that is expressed on the cell surface, in the cognate antigen, and the functional alterations. Okay, structural and functional alterations. You have the NMDA, LGR1, CARP, so on. And now, for a substantial number of them, but certainly for the most common, like NMDA, LGR1, Casper, GABA A, GABA B, AMPA receptor, for IGLON5, for all of them, there are animal models of passive transfer of antibodies. So you passive transfer of the antibodies, human antibodies to animals, and you see in the tissue, you see the same effects that you see in cultures of neurons, so that's good. And in addition, you see that they cause behavioral alterations. And then there is a third sort of degree of proving the pathogenicity, is that the models of active immunization. And so far, there is only one model of active immunization. There are multiple approaches, all successful, of active immunization for NMDA receptor encephalitis. There have been attempts for LGI1, but so far not really clearly accomplished, right? So there is all these three steps: cellular, passive transfer, active immunization. And only active immunization for an NMDA receptor encephalitis.
Thank you so much, Josep.
Professor Dalmau, just a quick question. In a patient who is a young woman who is refractory to all treatment, especially the interesting cases you showed, the long vegetative states, in a young woman, is it recommended to do oophorectomy when on imaging you don't see a teratoma? Is it a therapeutic procedure that one would recommend?
Yes, here there are several angles that are very, very delicate it's very difficult to give you a straight answer here. What I can tell you is in this study that I show you at the end, This is what happened in some patients, not many, some patients that they have, people were desperate, of course, it's an extreme clinical situation. And they have oophorectomy. Initially, they had one, and later they had the contralateral and so on. In most of these cases, they did not find any tumor. Okay, sometimes you have a microscopic tumor, but in many of them, they didn't find a tumor. So we have never been in favor to do blind oophorectomies to patients with NMDA receptor encephalitis, which surprisingly are being done sometimes very early. Bilateral oophorectomies, then there is no we don't support that. But in extreme situations, it's something that you can understand that people do it. We have recommended that, I believe, in all these years, in a couple of patients, more than recommend. When people ask our opinion, who said that it was reasonable, people that have been more than 1 year in coma and basically no tumor was found. What I think is important, I didn't say that, for the treatment of this disease is to be aggressive from the very beginning fast. I mean, people give tocilizumab, bortezomib, and when you look at the literature, there is very little evidence that this works, because many times, or the few times that these patients have been reported, they receive other treatments at the same time. And so I think it's important. So they prefer these sometimes, physicians, they feel more comfortable because these drugs are less toxic than cyclophosphamide. In my opinion, cyclophosphamide is much better than them. And we use very frequently rituximab and cyclophosphamide very early in the disease. This is an impression. It will need a clinical trial to see the effects of these third-line therapies.
Can I just ask one question? Professor Dalmo, in Sri Lanka, fortunately, when it comes to treating these conditions, we have most of the IV methylprednisolone, rituximab, plasmapheresis, IVIG, things like that are available. But unfortunately, when it comes to diagnosing, we don't have, the necessary diagnostic panels freely, especially when it comes to autoimmune encephalitis. So especially in the garment sector, in your opinion, what are the antibodies, if we are to prioritize, which antibodies should be focusing on?
Well, mainly, again, mainly the two lead disorders are NMDA receptor encephalitis and LGI1 encephalitis. These are basically almost 65-70% of the cases, or even a little bit higher, are LGI1 or NMDA receptor encephalitis. If you have a child or you have an adolescent that presents with acute encephalitis, you basically have to think about MOGAT or NMDA receptor encephalitis. You're not going to see LGI1. Of course, there are always exceptional cases reported in the literature, but basically in clinical practice, you rarely are going to see a child with LGI1 or Casper2. Basically, most of them are MOGAT or NMDA receptor encephalitis. And in adults, it's different. In adults, you can see the other ones also, of course, but still NMDA and LGI1 are the most frequent ones.
Thanks a lot. So we have come to the end of the symposium. Let us show our appreciation to all three speakers in the usual way.